Welcome to today's program, Equal but Different, Top 5 Issues Women Face in Addiction and Recovery. I'm Gary Enos, editor of Addiction Professional magazine. Today's program is made possible by our sponsor, Caron Texas. Thank you to Caron Texas and to you and our audience for giving us your time and attention. Before we get started, we have a few housekeeping details. Today's program is interactive. Our speaker will answer questions at the end of the presentation, so please use the Q&A feature on the left-hand side of your screen to submit a question at any time during the presentation. The scale button on the toolbar at the top of your screen scales the presentation to fit your screen. On your left is a box labeled Handouts, where you can download a PDF of the program slides. For those seeking CE credit, you must be registered for today's program to receive credit. During the program, 2 messages will appear on your screen. If you are participating as an individual, enter the attendance code, which will appear twice on your screen throughout the presentation, to verify your attendance, as this is required to generate your CE certificate. After the program's completion, please stay in the room as a link will appear that will allow you to generate your CE certificate. If you are participating as part of a group, write down the 2 CE codes that will appear on the screen throughout the program. Everyone registered for today's event will receive an email following the program, which will provide a link to allow you to verify your registration information and attendance codes to generate your CE certificate. We also invite you in our audience to share your thoughts with your colleagues. Share your thoughts about today's presentation with your fellow professionals via Twitter at the event hashtag #WomenInAddiction. At this time, it is my pleasure to introduce today's speaker, Brenda Iliff. Brenda has been in the addiction field for over 20 years in a variety of settings, both as a clinician and administrator. Brenda has a Master of Arts in Counseling from Regent University in Virginia and a Bachelor's in Chemical Dependency and Gerontology from Metro State University in Minnesota. She helped to establish several programs, including Hazelden's Women's Recovery Center and its Florida facility. Brenda is the author of the book A Woman's Guide to Recovery, as well as numerous articles on addiction and recovery. She regularly speaks to professional audiences on gender differences in recovery, older adult issues, food addiction, and ongoing recovery needs. She has appeared on Good Morning America, Air America Radio, and she has had several appearances on public television. Thank you, Brenda, for joining us today, and with that, the audience is yours.
Thank you, Gary, and thank you all for joining us today. We are so pleased to be able to talk about a topic that's really important to many people, particularly those that love women and addiction. There she was again. She was young. She was old. She was tall. She was short. She was Asian. She was Caucasian. She was beautiful. She was aging. She was traumatized. She was anxious. She was Hispanic. She was African American. She was gay. She was straight. She was bright. She was struggling. She was thin. She was obese. She was an executive. She couldn't hold a job. But there she was again. There she was again, with her eyes downcast, wondering if anyone knew what might be helpful to her. There she was again, a woman in addiction. We're going to talk today about women in addiction, and we're going to talk about women in recovery. The objectives are listed on the next slide, and you'll see that we're going to talk about what the research says about women, some of the differences. Yes, addiction is addiction, but it is different for women and men. Part of that difference is because of physiological concerns. Our brains are created very different. We're going to look at roadblocks for treatment for women seeking addiction, and most importantly, what might be some addiction treatment concerns specific for women, as well as recovery and relapse concerns for women. As women, we're created equal but different. We get addicted for different reasons. We go down faster, we recover differently, and we relapse for different reasons. You know, many years ago, the Big Book of Alcoholics Anonymous told us that women progress faster. And what we're learning now through the research is why women progress faster. That said, even though women progress faster, I would argue that recovery is a natural for women, and we'll talk about why that is. You know, for those of you who like the research, unfortunately, there's not a lot of research out there for women and addiction. Later in the slides, I'm going to refer you to a book called The Female Brain, and it's written by a neuropsychiatrist who was trained at an Ivy League school, and she's brilliant. And she talks about when she was in her Ivy League training, raising her hand in a class and saying, how much of this research is done on female animals, female rodents, female gorillas, whatever? And the professor laughed at her and said, why, of course, none. Their cycles would screw up the research. And those of you who are true researchers know that's true, because in order to do true research, you would have to have, say, 500 rats on the first day of their cycle and compare them all throughout the research. And we don't have the resources, obviously, to do that. That said, that also affects the substance abuse field. There's not a lot of research on what's different for women and men in recovery. That said, there is some research, and we'll direct you to some of that. One of the first attempts at research was a study done by the AA Grapevine, and those of you who are in recovery may know what the AA Grapevine is. It's a little journal that people can subscribe to that's sent to members of Alcoholics Anonymous if they want. Many years ago, they mailed out a survey to the people that subscribed to the AA Grapevine, and they mailed out about 1,600 surveys, so the numbers are real small, and only about 10% returned the survey. But of those people that returned the survey, 98 people described their addiction in one way, and 15 people described their addiction in a very different way. Well, what would you do? Of course, you're going to use the 98 as the more general number of around what's addiction. And they've done that, and so much of our treatment was based on what those 98 people said. What do you think was the difference between the 98 and the 15? What might have been the difference? Well, let me tell you. The difference was that the 98 were men and the 15 were women. There's not a lot of research out there around women and their addiction needs. I will point you to one particularly really good book that's free. It's published through our government, through SAMHSA, and you can go online and order it, or you can download the PDF. It's free, but it's called Substance Abuse Treatment Tip Number 5, which addresses specific needs for women. Another resource that we wrote a few years ago was a resource for the woman in recovery that talks about what are some of the differences for women in addiction, what is addiction, but more importantly, what can be done to help women get in recovery. And that I wrote when I was the director of Hazelton's Women's Recovery Center. It's called A Woman's Guide for Treatment. Today we're going to talk about women in general, but we do know that women are not homogeneous. In fact, there's a whole continuum of women, and there may be more variability between one woman and another woman than there is between one woman and a man. So a lot of what we're talking about today is about generalities, but these generalities do prove true a lot of times with women in addiction. Throughout the screens, I'm going to be giving you a lot of stat slides, and these are really more for your future reference if you want to learn more about and go deeper into some of the topics we're talking about today. The first slide, I do want to point out that in general, males have more abuse and dependence of alcohol and other intoxicating drugs. Although if you look at the young people, the young gals are keeping up with the guys. Okay, we're going to get you involved at this time. Okay? We're going to be doing a survey. We're going to be doing 3 different surveys during the presentation. And what we'll do is we'll put up a survey question, and then we'll ask you to take a look at the question and vote on what you think is the number one issue. This first question is, what is the number one issue that women face in addiction and recovery? What's the number one issue that women face in addiction and recovery? And we're going to give you about 30 seconds to answer it, and then I'll come back on the line and we'll say, where are we all? Okay? Thanks. Okay, it looks like some good participation. We're going to be closing it in about 5 seconds, so if you vote, okay. All right, you can all see the percentage that voted for what issues do we need to look at when we're talking about women and addiction and recovery. Wow, some great participation. Looks like, according to the group out there, people think the number one issue that we got to look at is barriers to treatment. And that is a big issue. That is in one of the top 5 here, so that's great. Another issue that rated very high is trauma, and that's great too because we do need to look at trauma. Mental health concerns, absolutely, and addiction as a concern, absolutely. I would argue that the number one thing we need to look at with women in addiction and recovery is addiction. Addiction is addiction. And if we don't treat that, we need, excuse me, I'm having a little techno difficulties. Okay. Addiction is addiction, and that's the number one thing we need to focus on in getting people in recovery. You know, the bottom line is those other issues are really, really key, and we will address those. They're very important. So those of you who voted for those, I'm in no way minimizing those. But unless we treat addiction as addiction, we can't help people with those other areas. You know, we know that addiction is a real mess in people's lives, and it can cause a horrible mess in people's lives, but we need to bring it back to addiction is a brain disease. And while that's way beyond the scope of this presentation today, it takes away a lot of the concerns around morality and that whole piece, that people's brains are affected very different once they become addicted. We know that it's a spiral downward. It's very progressive. One of the pieces that's different for women and men is that most women are central to the stability of their network. That means they're kind of the coordinators of their network, whether that's being a mom, whether that's being an oldest daughter, whether that's being a caregiver for someone who's sick, whether that's being a sister. A lot of times women tend to be central to the stability of their network. So when they go down, the network goes down also. For those of you who need one-on-one on addiction, which I know most of you don't, bottom line is addiction is a mess. There's lots of sneaking and hiding. There's also a lot of preoccupation, and I call that monkey chatter. The whole mind saying, but what about this, and what about this, and oh, you can have just one. And so much focus is spent on the addiction when people are addicted. Also, shame and hiding are a big part of addiction, and we need to help women with that. Shame is about feeling guilty for who one is, and many women just feel tons of shame just for who they are, just for being, like they don't deserve to breathe the air in the world. Then you add on addiction, and that can really keep people stuck in the shame. Some women struggle with shame about the actual drug they're using. I've known women that are middle-aged using meth, and they don't want anyone to know they're using meth. It's one thing for people to know they're using alcohol. And then there's also shame around preoccupation. Bottom line, with women in chemical dependency, it is not a single-dimension issue for women. In fact, I would argue that addiction is not a single-dimension issue for men either. However, for women, there's 2 things that, according to Stephanie Covington, women share, and the one is an experience of trauma. That many women you'll be seeing who are addicted, and many of you voted that that's the number one issue. It is a huge issue women face in addiction. But also lack of healthy relationships, and part of that is because of what the disease does to people. So we said women are equal but different. We start using for different reasons. We get addicted differently. We go down faster. We relapse for different reasons, and we recover for different reasons. Some of the reasons that boys start using is the recreational use. I've taken the liberty in this slide to put in parentheses relapse concerns, because if people are starting using when they're younger, it's very likely that they may start using again because of these concerns. So when we're looking at guys, maybe going fishing could be a relapse concern. Not that there's anything wrong, but we may need to provide some education around. You may start using again because of the recreational use. They also like the feeling of the drug. With women, it's about connection. Young gals start using because they want to belong with their group and they don't want to hurt somebody else's feelings by not using. Another study talks about the number one reason young gals start using meth, get this, is to lose weight. And I remember the first time I heard that, I thought, oh, brother, that can't be true. But if you look back at history, remember Mama's Little Helpers, those little white pills that women used many, many years ago? There is something about eating disorders, body image, the view of one's food and body that really plays in to chemical use. Also, with women, I want to point out from another study that people are susceptible to initiating their addiction because of things like their partner's using, they want to keep up. And again, here eating disorders is listed, but also trauma is listed. This is from the TIP book that we talked about earlier. Stephanie Brown, who many of you know from being in the field for years, wrote a few years ago, historically, women's use of addiction to alcohol and other drugs is closely related to their dependence on men, including their doctors. And this is not about blaming doctors. This is not about blaming men. I would argue that really many women's use of addiction to alcohol and other intoxicating drugs is closely related to the quality of their relationships and to their dependence on those relationships. What we do know is that women and men are created very different. Obviously, that's not rocket science. As women, we're more efficient in how we use our alcohol. Did you know that, people? That we are more efficient. And here's why. Physically, we're created very differently. As women, we have less of an enzyme in our stomach called the alcohol dehydrogenase enzyme. This is an enzyme that breaks down alcohol. So the alcohol goes into our stomach. We send it out into our systems much more concentrated. So we're more efficient. It gets out into our system more concentrated. And then as women, we have less water in our system, but more fat in our system, so we absorb it more strongly. So that's why they say, we break it down less, so it's more concentrated at going out into our system, and then we absorb it better. So that's why they say one drink has twice the impact on a woman than it has on a man. And I used to think, well, that, of course, because most women are smaller than men. But that's not what it's saying. What it's saying is if I have a 150-pound woman in front of me and a 150-pound man, that 150-pound woman will have twice the physiological impact from that drink than the man. And that twice means twice the impact, almost twice, on her organs. Organs which include liver, organs which include brain. And those of you who've worked with women in addiction know that we see a lot more cognitive damage because of that physiological concern. You ask about other drugs. There's not a lot of research out there. Stimulants, what we do know is they have a greater effect over the menstrual cycle. That's a little different than men. Not much studies about marijuana, heroin with the menstrual difficulties. And what we do know, and we mentioned earlier, is women are more likely to abuse prescription drugs than men. Physical risks, what's the difference between younger women and older women? I was asked by someone to define what is a younger woman. And generally, a younger woman would be someone in their teens and or 20s, and then older women would be more the 30s, 40s, 50s people. What we do know is that younger women get hooked faster, and that's because what we used to think is the brain was fully developed by the time someone was 10 years old, because it weighed the same as the adult brain. But what we know now is that the brain is not fully developed till people are about 24 years old. So if you put drugs or alcohol in a developing brain, whether that developing brain is inside its mama or whether that developing brain is in a 15-year-old, 16-year-old, 10-year-old, 12-year-old, there will be some sort of brain damage because the brain is developing. So we see more of that with the younger women. We also see a lot more risk of STDs. With older women, the concerns we see are more about aging concerns, real strong aging. And those of you who sometimes I've seen women that are 40 years old and they really do look like they're 60, and that's due to the disease of addiction. Mortality is really difficult to measure because there's a lack of accurate reporting. We all hear that Whitney Houston died because of drowning, and bless her memory and bless her soul. That's very true. She did, but we don't know whether chemicals were related to that or not. And I'm not saying that she did die because of addiction, but I am saying that there's a lack of adequate reporting for many people, that the thing we say that they died of really is true, but what was prior to that was based on addiction. I did put this slide in here because I think it's important for us to know the highest mortality risks for women are middle-aged women for mortality. We said physically women are very different than men, and that's true. But that starts way, way, way before we're born. And thank you to the men that are joining us today. I appreciate your interest in women and addiction. And I think you'll find this particular slide especially interesting, as I do think the women will too. Did you know that every brain inside its mama starts out as a female brain? Men, your brain started out as a female brain too. Just like women, your brain started out as a female brain too. What happens at 8 weeks is testosterone kicks in, and that's when the male brain starts to develop. And they're able now with testing to see that several things happen when that testosterone kicks in that make it a male brain. What happens after the testosterone kicks in is that the communication center shrinks. The hearing cortex shrinks. And the part of the brain that processes sex becomes twice as large. Why are you laughing? Can you see how that affects us throughout our whole lives? That's separate than any judgment. That's the way we were created. So separate from race, separate from ethnic, separate from the way we were raised, our brains are very different. But can you see that practically and in reality? They say women use about 20,000 words a day. Men use about 7,000. Thoughts about sex enter a woman's brain every so often, a men's brain much more frequently. I would argue that women are wired with connection. We say that men talk in words and sentences, and women talk in pages and paragraphs. If you're curious about that, if you have a male partner, ask him, how was your day? Oh, fine. And if you have a female partner, ask her, how was your day? Well, let me tell you about. Do you see that, how it happens in everyday life, how women are more likely to communicate? And that's because of their brains, the way the brains are created. I would argue that recovery is a natural for women. Many years ago, Judith Miller wrote a book called Towards a New Psychology of Women. And she said in that, a woman's primary motivation is to build a sense of connection with others and to connect with others. And ultimately, recovery is about that sense of connection. That sense of connection with ourselves, that sense of connection with others, and with a higher power or the world around us, whether that's nature or other people in the bigger world. In recovery, we need to teach women to develop relationships where women are not seen as competition for men. And that's why it's important to have some gender-specific treatment, if you can do it at all, because women start to bond with women. I worked with a counselor years ago, and she would always say, men will look at your ass, but women will save your ass. And that's really true in recovery, that women need other women that they connect with, that they're not seen as competition for men. For those of you who are strong in the 12-step program or big book people, you'll know in the book Alcoholics Anonymous, it talks about there's a solution for addiction. And while it's simple, it's not easy. And a big piece of that solution is about connection. The second part of the solution is about working the program, which is the 12 steps of Alcoholics Anonymous, Narcotics Anonymous, and those include connection also. Okay, we're going to move on to our second survey. So here's the next survey question that we'd like you to take a look at, and that is, many of you said barriers to treatment were a huge piece we needed to look at addiction treatment. So now we're going to ask you, what is the number one barrier for women getting treatment? If you would take and start to look at that and put your answers in, okay?
And just a reminder, while our participants are doing that survey, we will have time at the end of this presentation for some questions and answers. So please use the Q&A feature also on the left-hand side of your screen at any time during this presentation to submit a question, and we will get through as many of them as possible at the end of this hour.
Okay, we'll give you about 3 more seconds, and then we're going to close the survey and move on, okay? Okay, lots of voting. Great responses here. Okay, looks like from the group that the number one issue and barrier in women facing treatment, wow, way up there, social stigma. Actually, all of these are barriers for people getting treatment. And social stigma is a huge one, and we're going to talk about that in just a second. But the number one reason people don't get treatment, well, advance to the next slide. Number one reason people are not getting treatment is because they don't feel the need for it. And that may play into the fact that there's stigma. So we'll see that. But the number one reason is they don't want treatment. They may not be ready to stop using. They don't feel the need for treatment. I've got several different stats here that you can take a look at later. Other reasons are no children. And people say, well, that's a typo. No, it's not. How many of you have talked to women who've said, oh, I didn't have kids, and I figured, I don't need treatment. I'm not hurting anybody but myself. Children can be a real motivator for people getting into recovery. Another piece I want to point out is women sometimes can blame a sick child, and that's kind of a trump card, that they don't get in trouble at work, because what are you going to say to someone who's out sick a lot because they have a sick child? And those of you who work with women, ask those questions. How many times have you called in sick when really, for the sick child, when really it was you being hungover? Many of you said stigma is a huge issue, and you are dead on right. You know, stigma is defined as severe social disapproval. And many years ago, and somewhat today, but not so much, the words alcoholic meant loose woman. In fact, people that were in old-time AA many, many years ago, the wives of the men in AA weren't so thrilled when women started to become active in AA, because their stereotype of an alcoholic woman was that she was a loose woman. Many years ago, female addicts were there. They were just invisible. If mom was an addict, you just kept her at home and nobody knew, and you sure didn't talk about it. Now women are much more active in our society, and I would argue that they are visible, but there's still stigma. With addiction, it's very different for young women than for moms. There's also a stigma of various drugs. There really is a hierarchy in the drug world, and it depends on what your drug of choice is, how you see that hierarchy. But sometimes with middle-aged women, they don't want anyone to know they're using meth to try to keep up with everything and run their 2 businesses and handle the 3 kids, but they might be okay with saying they're using alcohol. Also the stigma of older women. Grandma, an addict? We see many women that because of, as we age, our metabolism changes and we react to alcohol different. Well, then you add on the fact that they're a woman and they react different. We see many women who are concerning all of a sudden around alcohol, but particularly prescription drugs. And then the stigma of one woman to another devaluing a woman because she's an alcoholic or addict. The next slide does tell you the primary substance use done by different races or ethnic groups. So we get them to treatment. What's the number one thing we need to look at in treatment? The Center for Substance Abuse Treatment identified 17 things that we need to look at when we're looking at women's treatment. And overall, we need to look at the addiction, but anything that impacts that addiction, we better be touching. The NIDA, which is the National Institute of Drug Abuse, they talk about really individualizing treatment, that individual treatment needs to be very individualized for people. And part of that is looking at what are the impact of being a woman on this particular person who's an addict. But also we need to look at if it touches the addiction, we need to touch it. So if anxiety touches the addiction, we need to look at that in treatment. Chronic pain, we're seeing a lot of people coming into treatment with chronic pain. We need to look at that in treatment. We need to look at coexisting issues, and we'll talk some about mental health disorders. You know, people say, is treatment effective? Treatment is effective, but it's about as effective as treatment for other chronic disorders that have behavioral components. We would no more expect someone with diabetes to go to an internationally known facility such as Mayo Clinic, get great education on diabetes, and then go home and do nothing. Not follow their diet, not exercise, not take medications if they need medications. With addiction treatment, we need to teach people that it's really about what are you doing daily if you're going to be in recovery, that it's just for today. What are you doing daily? We need to teach people that just like you would no more not change your clothes most days, we need to encourage them that you would no more not look at something for your recovery on most days. With women, it's real key in treatment, real key to look at their relationships. You know, we said earlier that women their primary motivation is around their connection with others. And there's several key pieces that we need to look at when we're looking at women and their relationships. Relationships can be a huge relapse trigger for women, and we need to address them. One of the pluses with women is women are generally trained to be more other-focused. And sometimes we pathologize that and say, oh, they're really codependent. You know, that can be a strength in recovery, that they start to reach out to other people. They're wired for connection. They want to be connected. Any treatment needs to involve the system in the treatment. And I don't know what the system is for the woman you're thinking about, but generally it's someone from the family. It may be their sponsor. It may be their probation officer, parole officer. It may be their psychologist. Who's the support system out there? But usually we need to get the families involved. And pleased to be part of Caron, and there's many other treatment programs that are really good about getting people involved, integrating the family into like a 5-day family program where they can come for free and get education as well as therapy around what's it like to live with an addict and what are some of the boundaries you need to set up for ongoing recovery. We need to encourage relationships. We need to, in treatment, talk about parenting. It's hard to go back to be the mom when you've been the child in the family for a long time. Also, sexuality. You know, women come to treatment with they're less likely to have strong desires, and they're also slower in their reaction time. But here's the good news, gals. Within a year, people are starting to feel good again. Recovery is a natural for women. We also need to look at spiritual concerns. When we look at spirituality, here's the definition of spirituality, and you're going to hear the term relationship again. Spirituality is the quality of our relationships with ourselves, with others, and with the world around us. And in treatment, we need to help people start to look at that. One of the concerns around 12-step treatment is that people are concerned about the term powerless. Now, because of trauma and other life situations, many women come into treatment feeling very powerless. The step 1 of the Alcoholics Anonymous program says we're powerless over alcohol and drugs. But if you want to see women with power, get them turned on to step 2, and that can be mutual help, getting women connected with other women that can help them. The addiction deterioration process starts out spiritually. People start by not being connected with themselves, not being connected with others. It moves to emotional concerns, mental concerns. As we said previously, women have more cognitive damage than men, and then ultimately to physical death. Recovery is the exact opposite. Women start to get better physically pretty quick usually, unless there's long-term damage. They start to clear up, first year and a half. Things might not be that clear, but it gets better and better and better. Emotions start to settle, and last but not least, it's about spiritual. The old days of bringing people into treatment and breaking them down and building them up, we knew that didn't work for treatment for women. I'll argue that it doesn't work for a lot of men, too. But on the left side of the screen, we have things that may be really helpful for women to focus on, although remember, women are not homogeneous, that many women may need to focus on some of the ideas that are on the right side of our screen also. But for women, it may be more about empowering and starting to see that they do, with connections with other women, do have power to get sober. I also think it's real important that we look at cross-addictions. Addiction is addiction. And addiction is a brain disease. And in early recovery, feelings are new and they're raw. And people are hurting. They're hurting. And they're real vulnerable to getting back into other addictions that they may have had previously or had through their chemical use, such as food, gambling, sex, relationships, work, nicotine, shopping, or they're real vulnerable to starting other cross-addictions. Those of you who've been in the field for years know that it's real common to see someone who maybe was anorexic, they put down the anorexic, or it wasn't quite so focused once they started the cocaine, because that controlled the weight gain. Then we get them in treatment, they start to gain weight, the anorexia raises its ugly head, and it's just a vicious cycle between the eating disorder and the chemical addiction. There are different rates of mental illness with different chemicals, and you'll see the sedatives seem to be the highest. But the most common mental health concerns for women with substance abuse are depression and anxiety, which are also the most common for men. We see a lot of that with women and men. But one of the difference that I'm going to talk about with women, and we'll focus on these two, is eating disorders and trauma. We know as eating disorders become more severe, substances increase. With women, people who binge, such as bulimics, compulsive overeaters, binge eating disorders, they're more likely to use alcohol. With dieting and purging, which would be more the bulimics might be more, and possibly anorexics with the stimulants may be more likely to use stimulants and sedatives. It's more likely to see people with substance abuse problems who are bulimics and binge eating disorder. We do know that chemical use has an effect on eating, and the next slide tells you hugely how chemical use has an effect on eating. Just because we pull the chemicals doesn't mean the eating changes, so we need to address that in treatment. We're going to do our last survey at this time, and would like to move your attention to the next survey question, which says, people who've had gastric bypass surgery are what? People who've had gastric bypass surgery are what? And we'll give you about 30 seconds to take a look at this. I'll give you another 5 seconds. Looks like a lot of people are responding. Great response. Okay. You can see the percentages up on your slide. People who have gastric bypass surgery are, here's the answer. People who have gastric bypass surgery are more likely to become alcoholics. And actually, they're more likely probably to become drug addicts, but we're not sure about that yet. The research isn't out there, at least that I'm aware of, but we know that they are more likely to become alcoholics. There was a survey done, and it was a large survey. It was done by the National Institute of Health. They surveyed over 12,000 people for over 25 years. And what they found out, this is so interesting, and many of you may know this anecdotally, but now the research is supporting this, that people who've had bariatric surgery are 4 times more likely to require inpatient treatment for alcohol abuse than the general population. 4 times more likely. We do know that people who've had gastric bypass surgery are more likely for abusing alcohol than the banding patients. And part of that may be because of the way the bypass surgery has people metabolize alcohol in a different manner. We also know that when people are trying to fill a hole, when you're eating and you can't fill that hole with eating anymore, you can fill it with alcohol and or narcotics, because people can continue to drink. Bariatric surgery patients overall have 2 to 3 times a greater chance of moving on to a substance addiction. And what we're seeing in the field is people that many years ago would come into treatment and they'd say, I never had a problem before my gastric bypass surgery. And we as clinicians would say, oh, they got to be in denial. They must have. But what we know now, after talking to families and some of the research, is they didn't have a problem prior to their gastric bypass surgery. Many people may have had a problem prior to, and we need to, pull that into treatment also. But it is a huge risk factor in people getting into treatment. We do need to look at some of the research around eating disorders. I did put several slides in here around what the research says around eating disorders. These are not studies with substance abuse and eating disorders. They also do not put in the fact that 12-step programs can be effective for people with eating disorders. Granted, people need education. We need the people in the field that talk to people about nutrition, getting understanding of what the brain happens with nutrition. We also need people to do therapy. But the next slide brings you to the idea that there may be food addiction for some people. And when you're talking about addiction, you're also talking about the need for long-term support. And if we get people sober, but we're not addressing the eating disorder, we may be not addressing a huge relapse trigger for people. The concern around 12-step groups for food issues is they're very different in very different parts of the country. For instance, if you're in Canada, Anorexics and Bulimics Anonymous is pretty strong in some parts. If you're in Florida, Food Addicts Anonymous can be pretty strong in some parts. If you're in Minnesota, Overeaters Anonymous, HOW can be strong in different reports. But there's many, many, many different types of food programs that are 12 steps for people. The concern is they're not strong in certain parts of the country. So you really got to do your research. The good news is there are a lot of online meetings for people now and a lot of resources, telephone meetings, that can help people to get that ongoing support, because so much of substance dependence and disordered eating is very similar. Ultimately, we need to get people educated around the addiction model, as well as teaching them that there's similar tools that they can use. They can ask for help. They can go to people that get eating disorder. Thank goodness for the people that really get eating disorders, because it saved many of women from relapse. Trauma also is a different issue for women in recovery. The stats are all over the place. I've seen stats from low numbers to 99%. Generally, the field tends to think that about 75% or more of substance-abusing women have a history of physical or sexual abuse as a child. The difference for women and men is that women are generally abused by people they knew and people that say they loved them. Men are generally abused by strangers and people that were known enemies, such as criminals in the criminal justice system, gangs, at war. But it's pretty significant for women to have to learn to trust again when the people who said they loved you abused you. We do know with substance abusing women that they have more perpetrators they have more frequent abuse, and they have longer periods of trauma. There's a lot of help out there around issues of trauma. Does this mean that trauma causes addiction? No, it does not. Otherwise, we'd have to say that women who are traumatized are automatically addicts, and then we know that's not true. But we do need to strongly acknowledge that trauma can throw people over into addiction, that it's a real issue we need to look at in treatment and recovery. And there's several really helpful tools that are evidence-based that can be helpful with that. Those days of just deal with one thing at a time are long past. We need to look at the whole person and what might be some relapse triggers. You know, we talked earlier about physiologically. We also are talking now again about physiologically. On the right side, we've got the symptoms of post-acute withdrawal. And these are the symptoms most people experience in the first year and a half, even up to 2 years of getting sober. That brain that was affected by chemicals, that same brain is healing. And during that time, women may tend to be more forgetful, lack of concentration, difficulty sleeping, can be oversleeping, can be undersleeping, over or underreacting, moodiness, labile, being very flat, poor concentration. Well, compare that to the slide on the left. How do you separate that from PMS? My gosh, talk about concerns in recovery. Women have hormonal concerns in recovery, and it's not true across the board, but for some women, it's a huge relapse concern for them. And these can change over the life cycle. So some women may be doing just fine, going through life, no big deal. They hit menopause, and things get bad. Some women may have horrible PMS. So we need to look at that when we're addressing women in recovery. And while we don't need to be the experts, we need to pull in the experts to help them, because this can be a huge relapse concern. Ultimately, a lot of it can be around teaching good diet, good rest, the importance of exercise, meditation, slowing down, getting support, going to the experts, getting medical support. Ultimately, it's about practicing the principles in all our affairs, and that can be doing daily what we need to do for hormonal concerns too, so that we can stay sober. You know, no matter how far down the road we've gone or what road we're on, there's always a ditch. And for women, that ditch is relapse. And once people have hit that ditch, we don't know where they're going to end up. So our job as clinicians is to try to prevent people from hitting that ditch. And for individuals, there's individual high-risk situations. You know, I wanted to show this slide because a high-risk situation for women in addiction recovery is beginning or ending romantic relationships. That, remember, we're wired for connection, and our sense of motivation and connection is about how we relate to others. This can be a huge relapse concern for women in recovery. And it's not just the ending relationships, it's beginning relationships also. That he loves me not. She loves me not. That can be a real relapse concern for women. So we need to provide support and education during those times. Also, physical pain. We need to look at chronic pain for people, because that also can be a huge relapse concern for women. You know, there's a lot of ongoing recovery concerns, and if you want to look more into them, we've given you a resource here that can help. For women, I don't know that there's anything sadder than getting a woman in treatment who's had 10 years of good recovery, but decided she didn't need to do it just for today. And just for today, over and over and over again, she decided she didn't need to do it, and things started to fall apart. Ultimately, for women and for men, recovery is about just for today. Just for today, what am I doing to be in recovery? Just for today. Just for today, just for this day only, I'm doing what I need to be in recovery. You know, I've heard women say they like the saying just for today better, because one day at a time assumes that there's more time out there. And some days can't handle that idea that there's even a next day. But just for today. Just for today. Just for today. There she was again. She was young. She was older. She was energetic. She was stoic. She was Asian. She was Caucasian. She was Muslim. She was Christian. She was an executive. She was a laborer. She was a mom. She was a daughter. She was wealthy. She was poor. But there she was again. There she was again, her eyes shining brightly, her head looking up, hope on her face. There she was again, a woman in recovery. Just for today. Just for today. Just for today, I want to thank you for joining us for this seminar. You know, as the clinical director of Caron Texas, I'm really proud to be part of the Caron Treatment Centers. Caron is the largest nonprofit national residential alcohol and drug treatment centers in the nation. We have over 53 years of addiction experience, and I encourage you to take a look at our website at any time to see Caron Texas, or to look at any of the Caron programs. We try to really incorporate a lot of what we're talking about into this webinar about doing gender-specific treatment for women and addiction. At this time, we're going to turn it over to get back to Gary, and we're going to move on to some questions. Okay?
Brenda, thank you very much. What an outstanding presentation today. And we have really received great feedback on what you've been talking about, and a number of very diverse questions. So I want to try to get through as many of them as we can in the remaining minutes, and we'll go a little past the top of the hour just to get in as many questions as possible. We had a couple of questions, Brenda, about the connection issue. And one participant asked, how can we help recovering women to see and feel the value of connection provided to them by family and friends? Any thoughts on that?
Well, a lot of it's about education. You know, telling people specifically, this is what you're wired for. And, you know, giving the hope of recovery is a natural for women. Also in programs, and I know there's some people out there that, you know, they might be a small outpatient program and have 6 patients and 5 are men, and, you know, you do the best you can. But whatever you can do to provide family education, a lot of times in early recovery, doing deep therapy with families is really like throwing gasoline on a fire. So, you know, as a clinician, you need to use your judgment on when you're going to start to do therapy, but always, always, always education can be really helpful for people. Another thing is groups. You know, getting families connected with other families who are struggling. There is, you know, we talk about stigma and shame for women in addiction. There's stigma and shame for men too, but for families. You know, how do you tell somebody that your mom is an addict, you know, but getting them connected with other families. A lot of times patients won't hear, or clients won't hear from their family what they hear from total strangers. And that's the miracle of support groups, you know, getting people connected with support groups. If they have the luxury of being in an outpatient treatment program or inpatient treatment, starting to hear from other people what they can't hear from the people they love most in the world. And that plays into ongoing recovery, too. You know, in ongoing recovery, many times people can't hear from the person they love most in the world what they can hear when they go to a 12-step group. You know, you're being selfish. Well, boy, you have their partner tell them they're being selfish, and woo, the cat claws come out, you know. So getting people connected, the more group work you can do with people, teaching them how to talk. Sometimes we'll have people do what we call a didactic, you know, giving them a little script about, okay, my name is, you know, but starting to have people start to take risks on that connection with women in recovery. Also, women 12-step groups can be really helpful for people because they start to see, oh, these women are caring about me. And then there's not the competition for heterosexual women with men. So, you know, when women start to dress up to go to AA, we got problems, and we see that a lot, you know. So I hope that's helpful. If you have, you know, please send in other questions around that. If it's not, or Gary, if you want me to clarify further, please say so.
Well, just to jump from that point a little bit, Brenda, I'm curious, what does research say about the effectiveness of single-gender groups versus mixed-gender groups or women-only treatment where women are treated in centers that serve women only?
You know, there's no research on, that I'm aware of anyway, on gender-specific therapists. We looked into that a few years ago. Because when we're setting up treatment programs, we want to know when you're dealing with addiction as the primary issue. Now, that said, when you start to move into trauma and a little bit later into treatment, it can be helpful to have a same gender. But when you're starting out with the education around what is addiction, that doesn't seem to be an issue. However, gender-specific groups are real key. Because if you're in a group with men and you want to talk about a step one issue, such as what you really did to get your chemicals, and it wasn't that you had a nice little job and you went to the drug dealer to get your chemicals, but you were part of the sex trade, that's not something you want to share with men. But that's a basic addiction issue that women need to be able to talk about. So it's real important. Many of the treatment centers out there are smaller. You cannot totally separate women and men, but if you can have certain groups that are just women to women or have them do that work in individual, they need to be taught or told that it's okay to talk about those things, but you may want to be wise in who to talk about those things with. The farther along down the continuum people are, the more helpful it is to get them involved into co-ed groups, if they can handle it. Now, that said, if they have a cross addiction, such as sex or love addiction, it's too distracting. It's way too distracting. So that's part of the individualization. I've seen many women who do just fine with co-ed treatment, just fine. Others, it's way too distracting. I've seen women that even if they are on a separate unit, totally separate, but they're on the same campus with men, it's still too distracting, and they need to be on a separate whole facility so that they're able to focus on the addiction. So there's where your clinical judgment really needs to come in.
Very interesting, Brenda. Switching gears for a minute, we have a question that came in. This individual wrote, "The number one issue I have faced in practice is helping women to realize they are involved in addiction. Do you have suggestions that could speed this process of readiness and awareness?"
You know, the research is pretty clear that motivational interviewing is very helpful. And so, if people are in what we call a pre-contemplation stage, what we do is we educate people. Educate, because you're not going to break through what in the treatment field we call as denial unless people have good education. And a lot of times it might be about educating the family, educating society, that it's okay to get grandma treatment. The whole piece about interventions, I know the field is kind of split on that, but many of the interventions nowadays are very caring. Let's have a family meeting. We're concerned about you. What might be some helpful pieces for you? So if you don't, for people out there, if you can get yourself some education on motivational interviewing, it is an evidence-based practice that's really helpful for how do we break down that denial that addiction is addiction. Another piece we really try to do is do education around the brain disease, because that takes away some of the stigma, and it is a brain disease, so bringing that in. Also having people start to look at what might be some, I wouldn't use the word consequences, but what might be some things I want to do to change my life, and going where they are. Where are they and what stage of change?
We had a question, Brenda, related to stigma. Someone wanted to know, is the stigma factor different for young women than it is for moms or women of higher age groups?
Yes, definitely. When we think about young women and it's spring break and they're out at the beach and they're partying and they're really partying down, all over Facebook, people have pictures of themselves drinking, probably not drugging, but, the two go very much together because most people use multiple chemicals. The bottom line is, with young people, it's kind of like we, as a society, think, with boys we say boys will be boys. with girls, we don't necessarily say that, but we kind of turn a blind eye to it. The stigma's not necessarily there. That's what you do on college break or spring break. But then you add, mom is drunk, or even worse, mom's on meth, or mom's living in a meth house with a kid. How does that feel to you? There's a stigma there. You know, we get child enforcement, CPS, CFS, whatever you call it in your particular state, involved when mom's involved. In working for a large treatment program, was the person who reported child abuse and child neglect, and we reported nationally, and rarely did I report child abuse and child neglect on a dad. Well, dads are driving kids drunk too, but we don't talk about that. There is much more stigma for a mom. And then if you add grandma in there too, we've got to talk about the older women, because older women are alcoholics and addicts also. Good question.
And Brenda, I think we're going to wrap up with this question, which I think could be considered a bit of a call to the field. This very perceptive participant asks, why is it that we continue to license women's programs without relationship involvement with significant others and family involved in treatment? It is so obvious the component is needed to face the shame and issues for relapse prevention.
Oh, very, very perceptive. Absolutely. And while I can't speak to licensing because it's different in every single state, I would encourage you to, if you're active in the field, to get involved and try to push that forward. You know, set up an outpatient program a while ago, and one of the criteria was if you come to outpatient, you bring somebody with you to the family program. And sometimes people would say, but I don't have any family. Okay, bring your sponsor. You need to bring a support person with. I don't care. Go bring a drunk on the street with you, but you need to bring a support person with. And it was amazing. We rarely got any pushback from that. We just set it up as part of the admission criteria, and rarely got any pushback on that, and would make an exception if it really, really, really was true. But I'll tell you, the women or men that were their sponsors loved to come. People want to be involved in relationships and helping others. So I would, you know, even though the licensing people might not make it part of the curriculum, you can make it part of that curriculum. Great question.
Well, Brenda, thank you very much again. And we're going to conclude the questions, and we're going to just wrap up here. I want people to know that for additional information regarding today's presentation, please feel free to reach out to Brenda Iliff and her team with Caron Texas using the contact information on this slide. That can be downloaded in the handouts area, which appears on the left side of your screen. Also, for more information about upcoming addiction professional webinars, be sure to visit us at www.addictionpro.com. That's addictionpro.com, and click on the webinars link. Also, feel free to join our online communities on LinkedIn and Facebook to share and participate in the discussion. Our LinkedIn group is called Addiction Professionals, plural, Addiction Professionals. Some final notes to pass along regarding CE credit. Those who have viewed today's presentation as an individual and want to obtain CE credit, please stay online and logged in. A link will appear on your screen in a few moments, and it will allow you to generate your CE certificate for this event. For those viewing as a group who want to obtain CE credit, please note that anyone who is registered will receive a follow-up email today that will provide a link to verify your registration information and the event CE code to generate your certificate. If you have any questions regarding CE certificates, please contact the CE Help Desk at the number listed here on the slide. Also, this program will be archived for 1 full year for your convenience and for sharing with your colleagues. Within the next few days, you will receive an email with a link that will allow you to download the presentation slides and view a recording of today's event. I want to thank Brenda Iliff once again for taking the time to speak with us today, and also thank Caron Texas for making today's program possible. And finally, thank you to all of you in the audience for participating. We hope you will join us in the future for another Addiction Professional webinar. This concludes today's presentation.